I'm Sumitra Khandelwal, and I wanted to give some tips and pearls for what to do if you've missed that refractive target. I think we've all had cases before. You come into the room, you ask the patient, hey, how's it going? How's that eye doing? And instead of the usual, it's great, everything's fantastic, they say, I don't know, I'm still pretty blurry. And when you take a look at the chart and you see that either myopic or hyperopic error, you think, what on earth? And the first step, I think, is to always kind of check the refraction, who did the refraction, maybe even do it yourself, and the vision. I've definitely had episodes where maybe it said +2 or +1.5 on the refraction, but the reality is the patient couldn't get to 20/20 and they just kind of went up and down, myopic and hyperopic, or maybe even with the astigmatism. And maybe they had some other conditions, such as like some macular edema, maybe some corneal edema, early PCO. So before you start going through this long refractive target checklist, examine the patient and make sure other pathologies are ruled out. The two that I kind of find are the most common are early PCO, for example, and then some mild temporal edema coming from the wound, for example. Second, you want to review your original calculations. It's like that Monday morning quarterback. So what happened? So one is, you can be honest, was this kind of a strange eye? Was it one of those narrow angles, that narrow anterior chambers that probably deepened and we're left with a myopic error? Was it a really large eye? Was there asymmetry between the eyes? Maybe one eye had a scleral buckle or another sort of pathology. And so check whether or not there's a reason for that. We have to keep in mind that even though through our best technologies and devices, cataract surgery is still not like refractive corneal surgery like LASIK with the 99% refractive target being hit. We still have these outliers, and even with the best formulas, you may still have those. Second of all, check the quality again of the corneal measurements and the axial length. And I even like to go back to the topography preoperatively and say, okay, so it looked fairly normal to me, but now that I know this patient had a little bit of a myopic error, or, maybe there was some irregularities here. Maybe there were some irregularities here that resulted in a hyperopic error. So that's really important too. And, if there's no explanation, please repeat the calculations in both eyes. And I actually repeated topography as well at the time. I've had cases where like mild ABMD worsened, for example, and that resulted in patients having an error, and they didn't need necessarily a different IOL. They just needed more intervention done for their cornea, and then a real look at their second eye to see whether or not the ABMD needed to be treated preoperatively in that eye. Ocular surface is also something to really look at, because you can't really do a good refraction on a patient who has ocular surface disease. You really want that cornea to be as pristine as possible before you decide, listen, this was a refractive target miss rather than just a corneal pathology that's tough to refract. And, then you have to decide, do I want to move on to the next eye? Let's say you had a 1 to 1.5 diopter hyperopic error or a myopic error. Those are pretty big refractive errors, especially if you're trying to figure out what to do with the second eye. Usually we like to do 50% of the adjustment of the difference. So for example, if you ended up 1 diopter myopic in the first eye, you take about half of that, which would be half a diopter myopia, and adjust the other eye accordingly. Maybe go for a little bit more hyperopia, +0.3 to +0.5. But if there's really big errors, you may leave that patient really anisometropic. But it's a tough decision too. I really prefer, if at all possible, to move on to the second eye, especially if the patient is relatively okay with the refractive outcome of the first eye. Because then if you have the same issue again, the second eye, if you want to do a corneal refractive procedure, you may be able to do both at the same time. But talk it over with the patient. I think that's the most common mistake that's made, is surgeons are like, oh, I don't know what to do, move on to the next eye. They don't really educate the patient and feel like they're communicating with the patient. I like to say, listen, your first eye didn't behave the way we wanted. We aimed for 0. We ended up with +1. We're going to make a little adjustment factor to the second eye. Unless you want me to do anything different with the first eye, I think you're going to have a great outcome. We'll get you there. But sometimes the eyes do behave differently than what the formulas ask for. And most patients are pretty understanding about that. I don't always do the 50% adjustment. There are some eyes that are unique, and therefore they don't really follow that rule of adjust 50%. Eyes where one axial length is longer than the other, one anterior chamber is narrower than the other. Maybe the first eye has actually gone into angle closure, therefore has a very strange anatomy versus the second eye that's just simply narrow. Maybe one eye had corneal refractive surgery. So various reasons why, if you believe the two eyes are different, there's no need to really adjust the 50%. The adjustment of 50% is really to try to figure out the effective lens position. And that's another education tool you can tell the patient. I can do the best corneal measurements. We can do the best measurements of how long the eye is. At the end of the day, your 1 millimeter in size IOL is going to rest in this 5 millimeter space, and we're not sure where it is, but hopefully we'll get it a little bit better the second time around. So the important things for me is 1, to go back to the old calculations, 2, repeat them if you need to, and 3, decide what you're going to do with the second eye, usually a 50% adjustment, and lastly, always, always, always communicate with the patients. Well, thank you. I hope this has been helpful, and you guys have a great day.